lumbar history is the most fundamental and important step to master in safely diagnosing a variety of different lumbar conditions. This is where you really start to tease out the correct thought process about how your exam is going to unfold and to catch problems that are of a spinal source that may not have any spinal symptoms. Somebody that presents with thigh pain or knee pain or shin pain or something. And clues that might help you to understand that you need to examine the lumbar spine. So this is a form produced by the McKenzie Institute. I find that it is a phenomenal tool for learning. It is not a form that you're going to be using in the clinic with an EMR, but it is a fantastic learning tool, and we're going to walk through it. And as you understand this form, you're going to be a diagnostic history taker. So let's start with the body diagram. Now, the body diagram is diagnostic. If the patient is reporting symptoms, say, right lumbar, and that's all the symptoms they have, if that's all they report, your next question would be, do you have any symptoms that radiate down the leg? Pain, numbness, tingling, anything like that? They might say yes, they might say they've got, oh yeah, it goes down my thigh sometimes, and they don't volunteer that information because their lower back pain is much more intense. It's what's concerning them, and that's what's on the forefront of their mind. So it's really important that you ask a follow-up question about the location of symptoms and really tease that out. They also might describe a non-related symptom. They might say, oh yeah, I've got knee pain. You take note of it, but it may or may not be relevant. But you need to understand all the symptoms that they deal with on that side. So that way, in case there is relevance to the lumbar spine, you can track it. But if this truly was all the symptoms that the patient was experiencing, then you would say, okay, well, I'm not dealing with a radicular problem. I'm not dealing with lumbar spinal stenosis, which would really need to have distal knee symptoms. You would say, well, these symptoms are on the right side, so maybe this is a problem with just something going on the right side of the back. Musculature, a joint that's just affected on the right side. You might need a unilateral treatment approach. You can also think about a chronic pain state that probably is not going on if that's the only symptom that they're describing. Now, if the patient describes symptoms that are bilateral, well, then it's similar if that's all the symptom they're having, but now we're dealing with a symmetrical problem, and it might require a symmetrical strategy versus a unilateral strategy when you think about exercise for directional preference or manual therapy, things like that. If a patient reports symptoms right here, well, certainly could be a lumbar condition, but you might also think if there's no symptoms above this belt line, it's truly over the SI joint or into the buttock, you might be thinking about, well, I might need to screen or at least get baselines for the SI joint in part of your exam. If the patient is describing symptoms that do this, then you might be thinking about a certain level in the lumbar spine. Maybe they've got an L3 level that could be affected, or maybe potentially they've got a hip issue that could lead to that distribution, versus a scenario like this, all the way down to their foot. Maybe they also have paresthesia. Now you're thinking a nerve root is absolutely involved, and it could be due to stenosis. It could be an unresponsive radiculopathy, something that's inflamed and needs an injection. It could be a lumbar derangement that has centralization. So you can immediately start ruling in and ruling out your classifications just based on where their symptoms are located. So that is a really critical step, to stop and just say, okay, based on where your symptoms are, what can I rule in, what can I rule out? When we talk about these 7 classifications, that's what you're trying to do, is get some of those off your diagnostic list as soon as possible. Narrow it down. So once you've covered that piece, the next step that we want to talk about here are the work and leisure activities. So really what you're trying to find out here is, what does the patient spend most of their day doing? Are they in weight bearing? Are they non-weight bearing? Are they flexed? Are they extended? So sitting versus walking, bending activities. If a patient were to say, I feel better in the morning and I get worse as the day progresses, you really should be interested in understanding, what do they do with their time? So if they said they sit a lot of the time, well, then you're going to say, well, okay, that is a flexion-based activity, and they're inactive and sedentary, and that might suggest somebody that needs more of an extension-based assessment or treatment plan potentially. Certainly activity in general and exercise, versus somebody who is better in the morning and they get worse as the day goes on, and they are working as a mail carrier and they're on their feet walking and walking and walking, and their back gets progressively worse, and maybe they feel a little better in the evening when they get home and they're sitting on the couch. That's the opposite. Maybe somebody has a flexion preference and they're sensitive to weight bearing and extension. So, understanding the demands that their spine goes through on a day-to-day basis is critical. Leisure activities is similar. If they were to say that on the weekends they play tennis or, some other recreational activity, well, what if they said they feel better on the weekend versus during the week when they're working? And during the weekend they're more active, and on the weekend or on the work week they're more sedentary. That would certainly help shape your ideas around diagnostically what's going on, but certainly also from a treatment standpoint, somebody who's a good candidate for exercise and activity. So that is really important to understand. But those are the two key pieces: weight bearing, non-weight bearing, flexion versus extension, sustained postures versus repetitious movements. Those are the demands that you want to kind of shape your thoughts around. The next piece here, this functional limitation, this is important because it defines a gap. And that is a huge piece of justifying physical therapy. If somebody were to say prior to the onset of this condition, they were able to do certain things, and now they are not. Maybe they've had to disengage completely, or maybe they had to pull back 50%. But that would be an important thing to document, is from a 0 to 100%. 100% is complete cessation of the activity, and 0% means they have not lost any percentage of that activity. You can define that and document it, and that will help define this gap in function and justify physical therapy. It also obviously helps you set goals. It helps you understand the demands back to certain things that they point out in these functional limitations. It helps you to understand what you are trying to get them back to. Your outcome score, this is, you could use several, but something like the Oswestry, some functional outcome measure. Your pain rating scale. Now this is, obviously everybody talks about this, but you want to get a range. You want to ask them the low point and the high point. Again, you want to define how much does the pain fluctuate? 0 to 10. How much does that fluctuate through the day? That's an important understanding of the behavior of your symptoms. That's kind of what you want to find out there. That can give you information about irritability. If certain positions or activities take them from a low point to a really high point, it gives you information about how irritable is this condition. That might gauge your exam intensity or maybe your home program intensity. So that's an important thing to understand. The present symptoms, that's just, again, currently, what are they dealing with? That just kind of cycles back to the body diagram and what they are currently dealing with in this episode. Now, present since, this is where you're looking at an acute to a chronic. Where are they at in this stage here? So, that will also help shape some of your thoughts about how stubborn is this problem. If it's an acute problem, that might make you think about certain interventions. Lumbar manipulation in a really acute patient, you might be thinking that's something that you might be able to use, where manipulation's been shown to be most effective in the acute phase. So that might kind of cue you into something that you might want to look at using, versus a chronic situation where, depending upon how long it's been present, that would maybe help you think about a nervous system component. So those things are important to glean. Now over here where it says improving, unchanging, or worsening, this is a great question too, because if a patient said they are getting a lot better, well, you might want to think about minimal intervention. You might want to think about counseling and education. But if the body is naturally taking care of the problem, we would want to let that process continue without over-intervening. We might want to be thinking about prevention of recurrence, but it might shape how you think about a treatment plan versus somebody who says they are worsening. Now, if they're worsening and the problem is, say, subacute, well, now you're thinking, okay, this is the first point where you really want to start thinking about clustering. So clustering is where you stack up clues. It's like, okay, they said this, they said this, they said this, they said this, and that's suggestive of a certain type of problem. So for example, if a patient says that they are worsening and the onset of the symptoms is subacute, and down here where it says commenced as a result of, let's say it is no apparent reason. They don't know. Over here, no apparent reason. They just said, it just started coming on its own and it's getting worse. Well, if somebody strained a muscle, if somebody, injured some soft tissue, one, you probably would have known when you did it, and it probably would have at least improved as they got out of the acute phase. So from a diagnostic perspective, what does that tell me about the type of problem this person might be dealing with? You might need to be more keyed into a red flag. If it's started out of the blue and it is worsening with time, your ears should be perked up regarding red flags. But you would also think about things like, well, when we talk about stiffness versus a derangement with directional preference versus, more chronic conditions like stenosis, you would have to think, okay, well, why would this just start all of a sudden out of the blue and just progressively worsen quickly? Certain conditions will behave that way and other ones will not. So that is a really important, these are combinations and connections you need to start thinking about making to get a good diagnosis. It's most common that patients will come in and the condition's unchanging. That's the most common scenario. That's why they're there. Either that or it's worsening, but most common is that it's just unchanging. It's just kind of stubborn. But those are some of the things that you're going to want to understand there. So commence as a result of, if there's trauma, especially in a direct access situation, again, you're thinking about a red flag. Doesn't mean it is, but it just means that you're going to want to ask follow-up questions. Again, the worsening, have they had imaging, things like that. Do they have neurological symptoms? Are the neurological symptoms progressively worsening? Somebody who has trauma and they're getting worse and they've got neurological symptoms that are getting worse, well, now you're really thinking, okay, this is somebody that we might need to get more information potentially before we proceed, especially in a direct access situation. So again, clustering, put clues together that amplify your information. It's really common in the lumbar spine that people will say it started for no apparent reason. There was no major issue. people are always trying to connect their pain to something, and they might attribute it to some previous event, years or months ago, well before the pain ever started. But we want to understand, can you tell me the moment you started noticing pain? That's an important question. That is a very important question. The moment they noticed it. First noticed. So, because it might be, well, I was just sitting there. And they don't attribute that, like, no way could just sitting there injure my back. But again, we're looking at the work, leisure demands, and prolonged sitting is compression to the lumbar spine. It is flexion of the lumbar spine. And that certainly could be a reason that symptoms could start. It was just prolonged static flexion, putting stress on the back. So try to get that. Try to understand when they first started noticing it. What were they doing? What was the moment when they first started? And if it's so chronic, they've been dealing with this for years, they don't know. And that's fine. And that's, you'll just move on from that, and that's okay. Now, symptoms at onset right here. That basically is all that's saying is if the patient's symptoms were first felt in the lower back, and then as some time went on, it started to spread down the leg, that tells us that the patient is getting worse with time. They're starting to peripheralize, versus somebody that at the onset, they had back, thigh, and leg pain, and they might tell you that they are not improving, but they're so focused on their lower back that they're just basically saying, my lower back's not getting any better, but maybe all of the distal leg symptoms have abolished. So the symptoms at onset might be all of this, where current symptoms, present symptoms, might just be low back pain. So that's important. That would help us to understand if the condition is improving or worsening. Okay. Next. So this is a really important question, the constancy right here. This is important because, again, it becomes diagnostic and it becomes red flag. If somebody were to say that they had back pain that is worsening, it started for no apparent reason, and it is constant, their back pain is constant, then you would say, okay, is there any potential systemic problem going on that could be the reason for this random onset of worsening back pain that never goes away? Mechanical pain most of the time will come and go, even if it's for a small portion of the day. So how you ask this question, people commonly will say, I feel it all the time. And what they're really meaning is, every single time I'm doing this particular activity, I feel it. And so they say, I feel it all the time. Your follow-up question means every minute of every day. Every minute. That's the key question. Can you have 10 minutes of being pain-free? That's an important question to ask. 10 minutes pain-free per day? I mean, does it ever go away? So you're just trying to see, because if it does, if the symptoms are intermittent, then you want to understand when we get to the better section, okay, what are you doing when that feels better? Can you help me understand what you might be doing, time of day, activity, position, etc.? So that's a really, really important question to ask. Now, when you consider the leg, thigh, back, again, somebody might say constant because they're so focused on this lower back pain up here that they don't pay as much attention about the coming and going symptom of the leg, that it fluctuates. They just say it's constant in the back. So you got to follow up by asking, are the symptoms that you're experiencing down here in the leg, do you feel those every minute of the day? So that's an important piece to figure out. Now, in the better, worse section, that's pretty straightforward. We want to understand, the behavior further. And you can be pretty straightforward about these questions. You don't want to say, does bending make you worse? You want to say, do bending activities make your symptoms feel better or feel worse or don't really have any effect? That way you're not baiting the patient into answering a particular way. You don't want to suggest that a particular activity is supposed to be a problem to the back. So really make sure you keep that out of the language. But, obviously this is flexion. This is flexion. Rising right here can be fairly common for the lumbar spine where they're sitting in flexion for a period of time and their lumbar spine is flattened. And when they go to stand up and try to extend their spine, there's an obstruction. They feel stiff in their back. They can't fully straighten up. They have to kind of walk for a little bit before they can get fully upright. That would be a very strong clue for somebody who needs an extension-based plan of care. Possibly a lumbar derangement is a possibility in that scenario. It's just something you need to assess further. Standing, is that static standing? This is important. Sometimes if it's standing in line, standing talking to a friend, where you're truly just standing, versus standing and doing dishes, very different activity. Standing and doing dishes is actually bending. So you need to make sure that you differentiate between those two things. Standing truly means they're upright, not standing and bent over a workbench. That would be more bending. Standing and bending over a workbench would be sustained, weight-bearing flexion. So when you're thinking about an exercise, you might say, okay, well, if sustained weight-bearing extension makes you worse, what about non-weight-bearing extension? Or even weight-bearing extension, but just something the opposite of that will probably have an opposite effect. That's kind of what directional preference is all about. Walking, again, walking versus standing. Well, walking is a little more dynamic. There's a little bit of small rotation in the back. It's just more active and blood flow in general, so that might be a different effect. If somebody was better with walking, so they feel better with walking, and they feel worse with standing, well, then you're saying, well, weight bearing is not an issue. It's more about the static position or what they're doing when they're standing that's the issue, not the weight bearing. So these are little important connections to make. Obviously, somebody who says that they are worse when they're still and they're better on the move, that's really what we're hoping for, because we are movement specialists. We're going to prescribe movement. And so if they tell you that they're better on the move, it already says that they're probably going to respond well to a movement-based plan of care. Somebody who says they're better when they're still and worse on the move, that might be a patient, if you've ruled out things like directional preference and red flags and things like that, that might be a stabilization candidate. Somebody who needs more core stabilization to manage whatever activities that they're doing. Lying down, again, tells you if they need to be unloaded, maybe to start therapy, versus they can be in weight bearing. And then again, I already mentioned this previously, but as the day goes on in the night, so if they said they're better in the morning, and then they get worse as the day goes on, what are you doing through the day? That kind of thing that helps to shape that. Disturbed sleep, well, this could either be a mechanical or a red flag question, is really what that's all about. If they say they have disturbed sleep, you just quickly follow up with, well, what position do you sleep in? Is it positional? That's how you start differentiating between a red flag night pain versus a mechanical night pain. So that's, is the surface soft? Is it firm? And what position? And you could start immediately counseling them on maybe something you could do in therapy if it does look like it's mechanical. Previous spinal history, you're just looking at previous episodes. So if somebody said, oh, this has been going on for 3 weeks, but they've had 5 other episodes in the past, well, this is not an acute problem or a subacute problem. This is an acute or a subacute exacerbation of a chronic problem. So that would be somebody that, again, cluster things. If they've had this 5 times before and their previous treatments have all been passive, just manual therapy, massage, medications, injections, and it keeps coming back, Well, this is somebody you're going to have to be a really good educator with and help them to understand that the pathway that they're on, their current strategy of management, is poor. They need to make some changes there. Previous treatments, this can help you. Somebody came in saying, oh yeah, I've been seeing the chiropractor and I get an adjustment and it feels a lot better for a few days or whatever it may be. Well, that already tells me that this is a mechanical problem, most likely, because red flag problems aren't going to feel better for 2 weeks after a manipulation. So this is partly a safety question, but it also can be a question about things that might help you to know what you should or shouldn't include. If they've been getting adjustments for, or massage or whatever for some time, and it keeps giving temporary benefit, well, you may not want to think about that as a top tier intervention in your plan of care. So that's kind of why that's on there. Now, this down here, this is kind of our red flag section. There's in the course, we go over multiple red flag clusters that are more in depth than this section, but just a really quick top tier red flag clues are going to be things like your bowel and bladder for cauda equina, your gait to see if there's maybe an upper motor neuron problem or maybe just a really severe peripheral nerve entrapment, or if it's causing that significant of a functional problem, we might need to make sure that they're safe to be in physical therapy. Medications are important. If they're taking medications for osteoporosis, or they're taking steroids for a length of time, and they might have some soft tissue compromise, things of that nature that you might want to be aware of when you're prescribing manual therapy. General health, you really just want to get a sense of how do you feel? Do you feel well? Do you feel sick? Do you feel excessively fatigued? How's the general health? If somebody were, again, this is where you cluster things. If somebody has an onset of lower back pain, no apparent reason, it's progressively getting worse, their sleep is disturbed, they have a history of cancer, things of this nature, they're not feeling well, then, you're starting to think, okay, I've got multiple clues that are kind of making me concerned now. So those are, again, everything's about clustering. It's really hard for there to be one clue that it's just a slam dunk. Most things need clustering. So your surgery, that's if there's precautions in the surgical protocol or something. Unexplained weight loss, again, this kind of gets back into a potential malignancy situation. If a patient has had trauma, have they had appropriate imaging to rule out a fracture? So these are just some kind of low-hanging fruit type questions that will help you know if you can go forward with your exam.